that I haven't switched to a robot is because I've been happy with my outcomes doing manual instrumentation. We published that in JBJS a while ago, where we matched unis to totals demographically and radiographically. It's interesting, we use modified Coen Scott criteria to Nick's point, where we sort of expanded a little bit. I don't know anyone who uses the true old modified or the true Coen Scott criteria anymore, but isolated medial compartment osteoarthritis, minimal deformity, no autoimmune disease, and interestingly, we can talk about this in discussion. I don't consent. I'm one of the few people I've heard of. I don't consent for both uni and total. If they go to sleep expecting a uni, they wake up with a uni, unless something really bad happens. Because we published on this that there's not really anything you can see with your own eyes in the time of surgery that changes the outcomes of patient. And this is that paper. We looked at 147 knees that were fixed bearing, and we basically graded every cartilage damage we saw, and did it correlate with outcomes? The answer was no. So probably nothing you look at and be like, oh, I should do a total on this. It won't change the outcome. And that, you suggested that with a lot of your with your data. So the surgical principles: avoid limb overcorrection. I will tell you to avoid all polytibias. Thank goodness we don't see those much anymore. Balance your gaps. You have to have meticulous cement technique, bone spring cuts, and minimize your pinholes. Those are all sort of principles to abide by. And additionally, you got to look at the native tibial slope. So when you do it manually, you have to visually really take your time on the tibia. Interesting, as robotics came into the uni field over the last 15 years, it's been coincidental that we've also been merging the techniques in manually to linked devices, where it used to be we would cut the femur first and the tibia.